All right, why don't we go ahead and get started here? Again, thank you, everyone. My name is Joe Gogler. I am here at the University of Minnesota, very, very proud host of this really exciting dynamic event that we're so thrilled you joined us to be part of, the 411 on Dementia in Black Communities. I have just really quick, brief introduction here, and then we're going to get right to our very esteemed and wise panel. I always like to begin, and I think we all like to begin with a land acknowledgement. The University of Minnesota is located on traditional, ancestral, and contemporary lands of Indigenous people. I acknowledge with gratitude the land itself and the people. I take to heart and commit through action to learn and honor the traditional cultural Dakota values: courage, wisdom, respect, and generosity. And I think you're going to see in very vivid fashion that our presenters today and the exciting information they're going to be sharing with you will certainly live up to all of these really crucial values. Really proud to have sponsoring this event, first and foremost, the Minnesota North Geriatric Workforce Enhancement Program here at the University of Minnesota. And then also the Robert L. Kane Endowed Chair in Long-Term Care and Aging, located here in our School of Public Health. So as I mentioned, we are just so thrilled and honored and privileged to have this exciting panel assembled for you today to really answer your questions. The way we organize this panel is we want to make it as interactive as possible. So the first part of this panel today will be each of these esteemed presenters providing roughly a 7-minute answer to some of the questions you were kind enough to submit to us before during the registration process. And you'll be hearing today from the following experts. And I myself am so excited to hear from each of these wonderful individuals and the wisdom they have to share. We have Dr. DeLon Canterbury, a geriatric pharmacist, Dr. Fayron Epps, a geriatric nurse from Emory University, Ms. Robbin Frazier, our own wonderful expert and associate director in our Center for Healthy Aging and Innovation at the University of Minnesota. We have Ms. Dorothea Harris, a wonderful colleague, someone we've worked with for many years from the Volunteers of America here in Minnesota. Another really esteemed expert from Emory University joining us today is Dr. Kalisha Bonds Johnson, a psychiatric nurse practitioner. Also, longtime colleague and partner of mine in research is Dr. Lauren Parker, a scientist in the Johns Hopkins Bloomberg School of Public Health. Really excited too to have Dr. Kendra Ray, who's going to share with us some interesting perspectives as a creative arts therapist, expert also in occupational therapeutic approaches, and then finally myself as host. So again, really appreciate having you here. We encourage you to use both the question and answer function on Zoom and chat as well. I'm going to be in the background, but our speakers, if they have an opportunity, will also answer your questions via typing. I'll try to do the same. Otherwise, I am going to turn it over to our wonderful panel. And our first presenter today is Dr. Whoops, let me pull it up real quick. I should have known this by heart. Is Dr. Kalisha Bonds Johnson from Emory University. So Dr. Bonds Johnson, please take it away.
Yeah, no, if I can get my screen together, we will get started. My apologies, everyone. My time is ticking. Good morning, everyone. So as Dr. Gogler said, I'm Kalisha Bonds Johnson. I am here at Emory University. I'm an assistant professor as well as a nurse practitioner. And so I will jump right into one of the first questions that was given to me. And that is, you know, when we think about dementia and Alzheimer's disease, what is the difference? I really like this picture. It came from the Alzheimer's Association's website that just shows that dementia is what we consider an umbrella term. So if you think about the word color, then it's an umbrella term for purple, green, yellow. So then different types of dementias like Alzheimer's disease, Lewy bodies dementia, vascular dementias, they're just types of dementia. But this is and another reason I really like this picture is because it highlights the fact that oftentimes individuals will have what we call mixed dementia, which means they will have more than one type of dementia. The next question I was asked to sort of describe or talk about was the stages of Alzheimer's disease or dementia, the continuum or the trajectory. Because this illustration again came from the Alzheimer's Association's website, it specifically focuses on Alzheimer's disease, but I will say that the stages are pretty similar across the different types of dementias. The preclinical stage is where there are no symptoms. Research is suggesting that this often these changes in the brain start sometimes in individuals' 40s and 50s. So you may see research opportunities that are engaging individuals when they're in their middle adulthood. The next stage is mild cognitive impairment, where there are some symptoms of decline, but the individual typically still lives independently. Not everyone who has mild cognitive impairment will develop dementia, but everyone who has dementia will have had mild cognitive impairment, which is why it's so important to identify these symptoms as early as possible and to make a plan. Dementia is often referred to in 3 stages. That's mild, moderate, and severe. Some activities of daily living are affected in that mild stage, and many activities are affected in the moderate stage. When we think about daily activities, that's things like handling one's medication, managing transportation, feeding, dressing, bathing, managing money. And as the illustration says, there really is no definitive way to tell when someone's in the mild stage versus the moderate stage. I will say with the severe stage, it is a little easier to determine because the disease interferes with a majority of individuals' everyday activities. So you might be thinking, Kalisha, Dr. Bonds Johnson, what do I do if I'm noticing signs and symptoms in someone? I think the first thing to do is discuss it with that older adult. I say older adult because age is the greatest risk factor associated with Alzheimer's disease. And in many Black families, older adults are highly respected. So starting with them is key. However, this is a delicate situation. So I'll share a few tips I've used in my own family as well as the other speakers who are coming next. We'll address this in greater detail. The next thing to consider is including other family members in the discussion or checking in with other family members to notice if they are noticing the same things you're noticing. Every family is different. So use your own judgment with who and how many family members you should engage in this discussion. Navigating these conversations about dementia. So if there is an agreement with the older adult, I would recommend scheduling an appointment with the primary care provider. I'll share more later about the appointment with the primary care provider, but usually, again, it's a sensitive situation, and oftentimes the primary care provider is a little more accustomed to the older adult's medical history, and so it's just a good place to start. I would recommend coming prepared. One of the biggest downfalls with speaking with the primary care provider is the limited face-to-face time you have with the provider. So have your questions prepared and share the signs and symptoms you've noticed. Such as things like maybe she's having a hard time managing her medications or he's putting his pants on backwards. Whatever you notice, share that. Anticipate the possibility of multiple tests. Labs may be drawn to make sure there isn't something else medical going on. There is no blood test to determine if someone has dementia, so there may be some cognitive tests that can be done. Often this is done with a neurologist or maybe a geriatrician, so your primary care provider may have to refer their older adult out to specialty practices. But just with the cognitive test, we often learn key things about which parts of the brain are affected. So if it's memory, they may be having difficulty remembering more recent events. Or if it's the executive functioning area of the brain that's impaired, then multiple commands are often difficult. So telling someone to go to their bedroom, pick out some clothes and take a bath, they may not be able to do all 3. So breaking those things down. So we learn a lot when we do these tests, even if we can't definitively give a diagnosis. But what do we do if there's disagreement in the family? Navigating these discussions are difficult. And I often recommend suggesting, is there a favorite person that the older adult likes? In my family, that's me. So most of the time, my family comes to me when they want me to ask my granny different things. And I have a way of talking to her that, you know, she tends to open up better than other individuals. Continue to keep up with the signs and symptoms that you notice. Because if agreement happens and you end up getting an appointment, you'll be able to navigate that visit with the primary care provider or whatever provider you're encounter a little bit better. And then, do you have a provider that is trusted by the older adult? If so, this is the provider to start with. Since there is no exact lab, again, for diagnosis of dementia, this is often a difficult path. The one big thing I would really push for families to do is to be persistent with wanting information, gathering information, and getting a diagnosis or treatment. I will say sometimes primary care providers don't hear us when we're talking to them. And if they don't, I'd recommend you get another provider, because it's so important to feel like you have a rapport and that you can speak to the individuals when you're needing this diagnosis for an older adult. So seeking a formal diagnosis, this typically happens in two ways. The first is through the primary care provider, who often will refer you out to a specialist, as I mentioned earlier. The second option is through signs and symptoms when they are too great and the older adult ends up in the emergency department and or requiring an inpatient stay. And we would really like to avoid this if possible. So we can talk more about strategies to navigate getting a diagnosis, speaking with your provider. But that's all I have for right now. Thank you for your time. I will stop sharing and happily pass it over to Dr. Lauren Parker.
Well, thank you so much for getting the conversation started. I'm going to go ahead and start sharing my screen. Hold on one second. And then, okay. So I am Lauren Parker, and it is a pleasure to be here today. So before we get started, while I am a scientist, I also like to think of myself as a storyteller, and maybe I just like to talk a little bit about my family members. So if you see this couple here and this man here, this is my grandfather. His name is Melvin Parker Sr. So Melvin Parker is from North Carolina, and this is important to the story because North Carolina is also known as tobacco country. So he started smoking cigarettes, tobacco, when he was about 12 years old. And when I think a lot about my work, I really think about how I think about my grandfather, because in his later years, he developed vascular dementia. And my grandmother, who is on the left side here in this picture, she took care of him in his later years of life. And thinking about their relationship is so important when you're thinking about African-American communities and developing dementia, because he smoked cigarettes throughout his entire life from 12 until he passed away at the age of 75. And he loved his fried foods and he loved pig feet. Sometimes I'm like, how did you eat pig feet? Because now it just makes me kind of squinch up my nose, but I used to eat it with him. But that was one of his favorite foods. And that's really important to think about when we think about some of the things I'm going to talk about in terms of risk factors and rates for Alzheimer's disease in African-American communities. So what we know, or what we say about Alzheimer's disease in terms of the science, we say that African Americans are about 2 times more likely than white Americans to have Alzheimer's disease or other dementia. And this is important to note, is that it's not because one is an African American or Black simply because of their race, but it might be other cultural factors or behavioral factors that might be typical in these communities that make them have elevated risk for this condition. So some risk factors when thinking about Alzheimer's disease and dementia are, of course, traumatic brain injury. So I know we've heard a lot recently about players in the NFL, for example, who've had a lot of concussions, and they might have elevated risk for different types of dementias. Advancing age, that is a huge risk factor for having Alzheimer's, genetics, and depression. Also family history. But some of the things that we can kind of control outside of those factors are cardiovascular disease risk factors. So like I mentioned, my grandfather, he smoked cigarettes, and that was just something that was a norm in his time to smoke cigarettes. You know, there's a lot of advertising to be cool, you smoke, or different reasons why people smoke. And that's just something that was then. But now we have more knowledge and understanding about how smoking is a huge contributing factor to developing different types of dementias, especially things like vascular dementia. Obesity. I know personally, I like to comfort eat when I get like a little stressed out. So sometimes I might go and be like, oh, I want to go get something that might not be the freshest or something that might be fried. But those are things that might contribute to obesity, and that elevates your factors for having dementia as well. Same as diabetes and hypertension. So if we know that these are risk factors, we also know that those are things that we can do about it to kind of prevent or delay having Alzheimer's disease. So what are some steps for prevention? One step is exercise. So it's suggested to exercise about 3 to 5 times per week using moderate to vigorous activities. So some people might like to go to the gym and just pump out the iron. I myself kind of get a little like, ooh, that's intimidating. So some other things, if you don't like to go pump out the iron, is that you could do things like walking, gardening, doing things like yoga, doing things that are activities just to keep you moving and active so you can keep that blood circulating and keep your mind going and stimulated. Another prevention step is healthy eating. So I'll think about my grandfather, and I think about all the great foods that we used to eat and things that he grew up eating. And while those are great delicacies and things that we like to enjoy in eating, sometimes when I think about him, I think about how he really liked fried chicken or different types of chicken or different types of fried food. So instead of having those options, look for healthier options such as baked foods or incorporating more fresh fruits and vegetables, eating things like different types of berries and different types of fish such as salmon and other fish that are rich in omega-3s. Another prevention step is sleep. Sleep is so critical to managing your stress, managing how you function every day, giving your mind just a chance to slow down. Sleep is so important. It's estimated to get about 8 hours of sleep every night. I know some people say, I just can't sleep for whatever reason, but it's really critical to develop a good sleep routine. And some ways that you can develop a good sleep routine is to cut down on the electronics that you have before you go to sleep. Maybe have like some type of de-escalating situation, like taking a bath every night or having a cup of tea, something to get your body in a state of understanding that we're about to go into a state of rest. Let me calm myself down so that when you go to bed, you're going to bed and you're already at a relaxed state. So you can smoothly transition into having quality sleep that gives you about 8 hours if you can. And the last step I want to leave you with is stress management. Stress management is so important. I mean, we all have different types of stressors every day throughout the day. And we can't say, cut out stress, because it is good to have a healthy dose of stress. It's more so about how you manage stress. And it's important because sometimes when people have stress, they get wound up. So they're constantly like this, and they never come down from a heightened state of being aroused. So different types of stress management tools, such as journaling, praying, meditating, or other types of techniques like yoga or deep breathing might be helpful. One healthy tip that I really like to do is doing deep breathing. It's a simple exercise. Whenever you find yourself being really heightened or aroused, you can always have power in your breath. And some steps that you can do is to breathe in for 5 seconds and then to breathe out for 5 seconds. And you can do this for about a couple of rounds. And then after you do it, you can notice that your body really starts to soothe this stuff and to calm down. So I'm so grateful for the opportunity to be here with you today. And if you have any questions about anything I discussed, I'll be happy to share more. At this time, I will pass the mic to Dr. DeLon Canterbury. Thank you.
Hey, everyone, and thank you so much, Dr. Parker, for that lovely intro. Hope you guys are doing well. My name is Dr. DeLon Canterbury. I am a geriatric pharmacist and founder of Geriatrics. And so we focus on stopping harmful medications in our seniors and advocating using precision medicine as well as cost savings for our patients. So you may be wondering, why am I here in front of you today? I actually started this company 2 years ago, and a lot of it stemmed from seeing a lot of our seniors kind of falling through the wayside from the retail pharmacy setting that I came from. And so my grandmother actually was prescribed an inappropriate medication while she was in a nursing home. And so I wasn't a pharmacist just yet, but unfortunately her behavioral symptoms, her dementia symptoms, all significantly declined while she was just given this one medication. So it got so bad that the nursing home that literally prescribed it ended up having to kick her out of the very same nursing home in Brooklyn. And so my parents had to take in my grandmother from New York in Atlanta, where they reside right now, and take care of her for 4 or 5 months. And mind you, they were Caribbean, they were immigrant parents. And so a lot of this stuff was new to them to become basically full-time caregivers while having, 3 kids in college and trying to take care of themselves as well. So it was very difficult. And they didn't have an advocate. They didn't have a voice. They didn't have an expert to say, I think some of these meds may be a problem. And I feel sometimes we tend to underestimate the value of what the caregiver may see and hear with their patients, loved ones in this space. And so we neglect the meds. And I'm tired of seeing preventable harm done to our seniors because of just one medication that's legally written, that's well-intended, but again, gives me a job because we had to stop this from happening. And so today I wanted to share with you a little bit about who I am and why am I here, and then give a little bit of some updates on what we have in the world of treating some of these dementia symptoms. And unfortunately, as a lot of you know, there aren't too many cure-alls or treatments really available. We've had 5 core main drugs that tend to help with some of the symptoms, but it does not curb any progression of dementia or Alzheimer's diseases. And so really until the last 22, 23 years, we've had just 5 meds to choose from. So those were mainly our acetylcholinesterase inhibitors like Aricept, donepezil, as well as other drugs that help with dopamine in the brain. So we've recently had the FDA approve Aduhelm or aducanumab, which is intended to attack some of those beta amyloid plaques in the brain that lead to the progression of Alzheimer's disease. And so that's been recently approved by the FDA, even though right now there is a bit of a longstanding battle on whether Medicare will pay for it or not. And that's still very much controversial today. So there is a pipeline of drugs called monoclonal antibodies, which Aduhelm or aducanumab belongs to. And it's one of the first of its kind that has been shown to directly target those amyloid plaques and reduce the pathophysiology behind getting progressive Alzheimer's. So it's really promising in what this world of drug class may open up for future treatments. There are about 3 or 4 more other drugs in the works that seem to have, in my humble opinion, a little better data and efficacy when it comes to their actual evidence and maybe improving cognitive impairment, but that's still yet to be determined. So in this space, there's one thing I do want to impart you all with, and it's to make sure you are leveraging your pharmacist, make sure you're doing and constantly asking what medications are really necessary. Is there a timeline? What can I do to get off of these meds safely? Because unfortunately, that is what leads to drug interactions. And we tend to neglect that there are drug disease interactions, drug age interactions. And so there needs to be a diligent war against the use of multiple meds that may not be necessary. And so in my job, my goal is to be that advocate for my patients. And I teach the caregivers and families on how they can best ask those right questions when you're in that office and maybe getting your Medicare annual wellness visit and you're doing your full med review, which is required. If you're not getting a full med review at least once a year, then there's a problem in your patient's care. So I'm mentioning this is aware to you all because we have to realize that 80% of all treatments come from drugs. They just do. And so if we're not diligent in what interactions are there, what genetics may be taking place, what meds may be interacting, and I mean all the herbals, all the over-the-counters patients may be taking. There are tons of false claims out there saying, improve your memory, improve your cognition, get your energy up. And we neglect that they can themselves have significant interactions with some medications that patients are taking now. So I always encourage patients to ask about every single med. I don't care if it's an herbal, a vitamin, whatever you think it is. Take the time to talk to your provider or your pharmacist, or of course your nurse practitioner, whoever's your provider. Talk to them about the meds. Talk to them about what is truly necessary. And a part of this work I'm doing, just so you all know, is to help with the largest recruitment for the NIH's dementia study. It's called the Preventable Study. And what they're looking at are, they're looking for 75-year and older healthy aging adults who literally want to know if statins, a common cholesterol medication, can actually prevent dementia. And there have been anecdotes from my patients who say, I feel a little foggy with the use of statins, or I've gotten some memory changes with it. We don't know for sure. We do not know, but we do know we need more minority recruitment to have an appropriate answer to this and really assess if statins can actually prevent dementia or worsen it. So again, make sure you're having those med reviews, talk about what's truly necessary. You may be thinking it's been good for the last 10, 15 years, but your body may not. And so it's important to always have an ongoing de-prescribing conversation, which is the safe removal of medications from our most vulnerable patients. So I want to leave you all with that today. Hope this was super helpful, and I'll be honored to speak more in the Q&A portion and further continue with that. So I will leave it to Miss Dr. Robbin Frazier to go from there.
Good morning, everyone. Thank you for joining us. Today, my presentation is going to focus in on how lived experiences, cultural values, and beliefs have implications for addressing dementia. I know we've got many providers online today, and so we want to share some of the findings that we have. One piece that I was asked to address is how is Black dementia care? How is it different? And what are some of the cultural considerations as you provide care? One of the important aspects to consider is the historical trauma and how that impacts beliefs. For many people, it remains that lack of trust in doctors. And you also have people that, struggle with the terminology used for the disease. When I first started my work, they're like, don't put Alzheimer's on the page, put memory loss and brain changes. And so, there isn't a consensus on the terminology, but we want to be flexible as we talk with families. One of the important pieces in care is understanding that your patient is very concerned often about being viewed through the lens of the disease. And people feel sometimes when they get that diagnosis and it's on their chart that all of a sudden, they're Alzheimer's or another form of dementia versus that person that is very present, living, and able to contribute. And so what happens is it leads to stigma and shame for people because they feel like they're not being regarded and valued for the things that they do. And so these things combine to create a culture of silence often with dementia care. One of the factors that I often hear from people in the community is there isn't a cure. So why do we got to talk about this? We'll just deal with it when it happens, and I'm not going to worry about it in the meantime. And so it's really important that we begin work on the diagnosis early, because what's happening now for many people in the Black community is that diagnosis is delayed. And by it being delayed, what's happening is people aren't seeing their family members, their neighbors living with this disease and making contributions. For some people, continuing to work. And so a lot of the lived experiences are there hasn't been a diagnosis, now there's a crisis. And then everything changes. People are like, they want my keys, they want to move someone in with me, all of these changes. And so for our community to have less stigma and shame and silence, they're going to have to understand that this is a longer trajectory, and that people can make valuable contributions and be involved. There is linked with kind of the trauma and the ongoing discrimination people face. We see that many of them want to remain in their community, and they want their family members involved with their care, because that's where the trust is. And the other aspect is there are successful models that include the faith outreach and support programs, which people are, very comfortable with, because their spiritual family is that second family for them in their church. So these are some of the areas where you see differences. In terms of overcoming the barriers, one of the things that's really important is to have active two-way conversations. I know Dr. DeLon talked about that in reviewing medications, but people are looking for that conversation with their doctor. And in those conversations, you can identify and address myths and misunderstandings. Sometimes people have not had the access to the information, and so that is contributing to how they feel and talk about the disease. And we know that our family members need culturally responsive community resources, because people feel like, I don't want to deal with this, because what's going to be different? Are there going to be resources? Is there going to be something to help me? And so by knowing those resources in the community, you are able to connect families with those. And then the last aspect here is really understanding what the resources are, the assets in communities. Our communities keep saying they just talk about disparities, everything is negative about. They're in our discussions with them. And so it's really important to involve the community members as you build your messaging, and also to have community involved with dissemination of the information so that it is culturally sensitive and responsive. And then the last piece here is just to focus in not only on the person living with dementia, but also the care partners. We know that over 65 to 75% of the people are working, and they are spending 26 hours on average in African-American families providing care. So we talk about the importance of self-care for the caregivers because their health can often decline. So these are some of the ways that you can address the unmet needs. And I will now transfer the baton to Dorothea Harris, a key community partner that's just doing some fabulous work with her culturally responsive services. Thank you, Dorothea.
Dorothea, it looks like you're still muted.
How about now? Can
Perfect.
you? Okay.
We can hear you.
All righty. Well, sorry about that, but thank you so very much, Robin. I am delighted to be here. I am the social worker and the director of the Culturally Responsive Caregiver Support and Dementia Services with Volunteers of America. And when I say culturally responsive, I don't mean culturally competent. Culturally responsive is reflected in our delivery of care within the culture norms such as hiring staff that are the same culture, showing a high level of respect, caring, and serving from an honoring perspective. Culture is also reflected in nuances such as our dress, artwork, our soul food diet, and our decor and mannerism. So as I've worked in community, providing boots on the ground services with caregivers and their families for over 18 years, I've learned and witnessed that culturally responsive services drives positive outcomes. Culture does matter. Next slide, please. Elders are highly honored and respected in the Black community. Multi-generational families living under one roof have always lived and cared for their elders, as well as providing care for old folks living alone in the neighborhood. Caring for a person with dementia is a family affair. Many times, dementia is not diagnosed, yet the commitment to care for family members, whether the sickness was called senility, senile, crazy, or dementia. Families work together to keep loved ones in the home or in the community where they could be guarded and looked after. For example, a family system may look like every family member having a delegate task and responsibility for the care of elders. This includes children too, called the sandwich generation. There may be distant caregivers that may provide monthly financial contributions. Another caregiver may live in the home with the care receiver. Another may bring meals over a couple times a week. And also, there might be another one that'll do the laundry or housekeeping chores. Also note that there is not always a primary caregiver per se. There are times when the name primary caregiver title is viewed only as a mainstream title. Caregiving in families is generally called a family affair. Whereas the Black family is profoundly resilient, the family system has changed. There are not enough multi-generational families living under one roof anymore. Not to mention that family members are living all over the United States and in other countries, which leaves many elders without the support of the multi-generational family system. In short, we are witnessing the heavy burden of more caregivers attempting this difficult, unselfish act of love alone. In contrast, culturally appropriate programs that honor and respect the history of elders, feeling the need to connect with their family of heritage, will make a positive impact when it comes to service delivery. Volunteers of America's culturally responsive caregiver support and dementia services are provided by a team of social workers, community health workers, and volunteers who are passionate and enthusiastic about serving the community. We reach out and serve our community by being visible throughout the Twin Cities with our Healthy Aging Memory Mobile Clinic, attending health fairs, community events, and frequently meeting seniors in their residence or community senior high-rises. We provide a helpline that seniors can call for consultation or just to talk. They can request a community health worker home visit or contact us to sign up for our evidence-based caregiver and our dementia classes, as well as join our bi-weekly senior programming. We offer various support services to caregivers so they can take care of themselves and also help them succeed at having their loved one in place at home for as long as possible. Some ways we integrate multiple caregivers is to form a caregiver support team. Family meetings are set up as a way to bring others to the table to have a conversation about how they may help with the caregiving responsibilities. Friends, relatives, community, and church members are all sought out to join the caregiver support team. With the help of a neutral person or a facilitator, each person can decide how best they can be helpful to the caregiver to minimize isolation and frustration. Asking for help when needed is extremely important, as caregiving for a person with dementia can be challenging and may lead to burnout and or depression. My suggestion for caregivers can be summed up in one word: ask. A is for ask, S is for seek, K is for knock. Knock on various doors and continue to seek for help. Because the VOA team is able to provide dementia education, support groups, coaching, and counseling to anyone joining the caregiver team, we have good success in keeping families together. However, in some situations, in-home healthcare agencies may be needed. This often involves providing respite or someone who can provide light housekeeping, meal prep, skilled nursing, and other services that may be helpful to the caregiver. Next slide, please. My second question was to talk a bit about transitioning to a higher level of care. So delaying nursing home placement while living in the community is just what it says, delaying nursing home placement, but just for as long as possible. There are any number of reasons when it's necessary to seek a higher level of care. Some prevalent signs of decline are on the slide. Other signs can be if the person with dementia doesn't have a support, community, or primary caregiver and has little to no visits from family, friends, or loved ones. Or if the caregiver is suffering from burnout. Possibly family and friends have expressed concern about them. This is especially true when the person with dementia lives alone. As a person with dementia becomes more fragile, confused, and experiences increased physical difficulties, an assisted living memory care facility or nursing care facility should be considered. This is especially important if the caregiver becomes ill and unable to continue care for their person with dementia. Placement is encouraged. Family members will continue to stay involved, spending much time in these institutions as their loved ones continue to need family to support them and advocate for their care. And the VOA's team also will continue to support families as they are placed outside of the home. Thank you very much. That's my presentation. I will pass the baton to Dr. Fayron Epps.
Thank you for that. And hello to all. This information has been so great. And I was given the task to address how to address resistance with care, best communication strategies for talking with someone that is living with dementia. And I want to start off by saying, excuse me, y'all caught me while I was trying to eat. I want to start off by saying, remember, everyone's situation is different. A lot of times as you are in this role as a care partner and caregiver, you're hearing from other people, maybe this works for them and this, and you're thinking, why doesn't it work for me when I am trying to support my husband or my mother? And I just want to make sure we all know everyone's situation is different. When you've met one person with dementia, you've only met that one person. And it's very important to know the person who you are supporting and assisting. That is so, so, so important. A lot of us come with different backgrounds, and especially, you know, the color of our skin may all be brown, dark brown, but our experience is different. And it's very important to understand that person's background, that history. When you do that, you will begin to understand why they prefer to do things a certain way, or why they are, quote unquote, resisting care. So for example, I had I do a lot of work in the community, in the Black community, and with faith communities, I should say. And I had someone share with me that, you know, she didn't understand why her mom was, when they would go to church, would resist and start fighting when people come into her personal space to give her a hug. This was pre-pandemic times, right? And it was very troubling to her. But what she had to understand, she had to take that time and learn more about her mother, talk to her aunts and uncles. And it came to find out that her mother had been raped when she was young. And so when anybody of the opposite sex would come in her personal space, it was bringing her back to that. And so that's just an example. I'm not sure this happens for everyone, but it's an example of how knowing that person, what was happening in the past that may influence them, quote unquote, resisting care or the difficult behaviors. And also when we think about the Black community, I want us to think about, you know, and it depends on the age of the person that you're supporting now. But if it's an older Black adult, remember what was going on 60 years ago, the life that they were in and what they went through. And so all of those things can influence what's going on right now, especially when you're trying to interact and support them. So it's very, very, very important. As a nurse, I learned early on, because they didn't teach us that in school, to be honest, but I learned early on, you have to know a person's history, know where they come from. You know, for example, I was caring for an individual and she took off her gait belt and started whooping me. I didn't, you know, at first I was young. I'm like, wait, hold up. But at that moment, I had to call her family and then we had to talk and I had to understand the error where she came from. I'm not saying it was right or wrong, but once I understood it, we can put things in place. And so that was just my example of just trying to, when I was practicing on the floor, is really how important it is to understand the background of the person that you're supporting and caring for. We also need to be mindful of how we approach the persons that we're supporting. Teepa Snow, we don't want to startle them. And Teepa Snow, I'm not sure if you all heard of her, but I'm a fan. She has some great tips related to positive approach to care. And she goes through a lot about how to physically approach someone that is living with dementia. And we know there's various types of dementia, over 70 types. And, you know, everyone always talk about Alzheimer's disease, but there's various types of dementias and there's a lot of different signs. Each dementia may have a different sign and symptom that is more highlighted than others. So it's important to know that. And when you approach someone, especially if their vision is impaired and you're coming from the side or the back, and you come up to them and you don't say anything, you're startling them. And, you know, I reflect on my days when I worked in the nursing home. That happened a lot because no one educated us on that. No one told us to make sure you come, you know, from the front, get down low on their level, hold your hand out. No one told us that, but that is so important because we would just come from the back and grab the wheelchair and say, let's go, you know, and you know, of course, the person is going to become quote unquote resistant because we startled them. We didn't give them a heads up. And it's just simple things like that, y'all. We need to just consider when we are supporting those that are living with dementia. I also want to recommend and suggest for us to try our best to join their reality. Many times caregivers tell me all the time, I can't, I can't do that. I just can't, and, you know, but yes, you can. Often we join the reality of our young kids, of grandkids. So you can do that. Last week I was at the hairdresser under the dryer and my dryer time, it was extended because my stylist knows that I work with dementia. And for those in the Black community know that stylists are also like a therapist. Because you sit in a chair and you just let everything out and you say everything. And she referred her client to me, had her sit next to me in the dryer. And we was talking about this, and she said, I just can't. You telling me to join her reality, and I cannot. And she was becoming so frustrated. And I had to listen to her and say, okay, tell me about your family situation. You know, we had Ms. Harris talk about the different family caregiving network and stuff like that. And so tell me about it. And she spoke so much about her grandchild and who has autism, but I used that as an example. How are you managing with him? Oh, well, I do this because I know this is what he likes, and he likes to be in this environment. And when he says this, I just go along with it. I said, why you cannot do that for your mother? You know, and it's sometimes, you know, often caregivers just get caught up on, you know, they cannot remember, they, you know, not trying to understand the disease process. And, you know, there's a lot of conflict. And I asked, can you just join her reality? If she thinks it's 1980, remember what was going on in 1980 for her, and just kind to join it. I also found out that there was a lot of frustration built up. And so all of this, that as it relates to resisting care and not being able to communicate, the caregiver herself was frustrated. She was really burdened, and she had no one to share it with. So I just want to take this moment, especially for anyone that is a care partner, that's attending a caregiver, find someone to talk to. If it cannot be anyone in your immediate family, talk to your hairstylist, the pastor, or, you know, someone to be able to talk. Because afterwards, she felt so much better, because she was like, "Ooh, I was carrying that." And all of that frustration, that energy was when she did communicate with her mom and interact, it was getting transferred, you know, because it's all in her. And so she probably wasn't. And she said it, I'm not the nicest person when I talk to my mom, because she's frustrated. And so it's so important. And, you know, I asked her, you know, would you like to join a support group? Of course, she said no. And, you know, and so that's something that we have to address in the Black community, that it is okay to talk to others. And there are support groups that are available where there's other caregivers, care partners, just like you, that's going through it. Because at this moment, this caregiver, this daughter, thought she was the only person that is going through this. And she said, they have other people? Yes, they have other people that's taking care of their mom and their grandkids. Yes. You know, so I think it's very, very important. And so when we are communicating, I brought up the frustration, and how when you're frustrated, you're transferring that over, and the person living with dementia can become frustrated as well. So we just need to really be mindful and know that it's okay. Once we recognize that we are getting to a certain point, boiling point, whatever you want to call it, that you can take a break, 5 seconds, 10 minutes, 10 seconds, whatever it is. And it's perfectly fine to take that break. The grits, the oatmeal, it's not going to get any colder if it's just sitting on the table. So, you know, I just want to let you all know it is okay for us to take that break, and that will help with the communications. To help family caregivers and care partners on their journey, I truly recommend for us all to become educated. And I appreciate all of you all attending today, and because it starts right there with education. And I believe, I'm a firm believer, there's never too much education, because we need to empower ourselves. And that's what often in the Black community, we do not seek out the education. I have a lot of people in my family think they just know it all. And they know it. Oh, I know it. But it's so important to hear from, like, Dr. Canterbury. Every time I hear from him, I'm learning something new. as it relates to medications and managing medications. And this is stuff that you would not get every day. So I really think through education, you'll get an understanding of the pathophysiology, the disease process. And then this will allow you to better adapt your approaches and interaction with the person living with dementia that you are supporting. The goal for me, the goal is for caregivers, persons living with dementia, to live and thrive on this journey. So as I conclude, I will put a plug in, and I think it just goes so nicely based on what Robbin and Dorothea spoke about, the cultural context and being culturally responsive, especially in the Black community. And I created a course with many others that are on the panel with me. They help with the Caregiving While Black education program. And it's really to address some of those things that go on in our community and no one talks about it. But we need to talk about it and also see how that intersects with being a caregiver, especially for someone living with dementia. So at the end of the day, we can be empowered and we can have better outcomes for ourselves, especially as a caregiver, care partner, and also better outcomes for the person that's living with dementia that we are supporting. So I'll put some links in the chat, and thank you all. And I will pass it on to Dr. Kendra.
Good morning. I'm so happy to be here and so happy to follow Dr. Epps. I'm just going to share my screen. Can you all see that?
Yes,
Yeah.
we can.
I thought it was only right for me to show you a picture of one of our residents who made this beautiful colored egg and chocolate meal over the weekend for Easter. And just want to say happy Easter Monday to those who celebrate. I am the Dementia Program Director at Menorah Center in Brooklyn, New York. I did hear someone mention Brooklyn earlier. The center is a 435 bed long-term care facility. I'm also a research assistant professor at NYU Grossman School of Medicine. I won't have a chance to talk much about our art program. Today I'll really be focusing on the music therapy program. But I just want to say that art is an amazing tool for many people who have dementia. Not everyone responds to music. So where I work, we do try to find multiple ways to allow people to engage and express themselves verbally and non-verbally. So I just want to start out by talking about the research that I've done at Menorah. Over the last 13 years, I've been at Menorah, and I'm sure many of you know that people with dementia can still process music even into the later stages of dementia. So it's so amazing to see that some people who cannot talk can still sing, and some people who cannot dress themselves are still able to sing full lyrics of songs or recall memories related to music. So music is very, very powerful, even into the later stages of dementia for many people. So what we do in our music therapy program is really try to address symptoms that are typical in a person who might have dementia, and that's agitation and depression. We also have studied and looked at how music therapy can be used to increase and improve well-being. And also we've done some research on how caregivers, paid caregivers, can provide music during their care. And I will say that we did do a very large music therapy study, which was over 130 nursing home residents. And we found that music therapy significantly reduce agitation and depressive symptoms. So it can be a very powerful tool for people with dementia. So just to talk a little bit about the music-assisted caregiving, this is something that is different that I think is not offered at a lot of nursing homes and long-term care facilities. We teach the CNAs, the certified nursing assistants, how to use music during shower time, during bathing, dressing, to try to reduce some of those resistive behaviors that you might see. I've also started a caregiver study where I'm working with caregivers who are at home, and we're trying to help and teach them how they might use these techniques as well. I'll talk about that a little bit more later, but in the picture on the top right, you can see there's a CNA who was working with a resident who used to be a boxer. And many times he liked to box, the staff. He wasn't sure where he was because of his dementia. But we started to incorporate using music with movement and doing some of those old boxing exercises that he did previously. And we noticed that it really did help to reduce some of those resistive behaviors and to improve the relationship between the CNA and the resident. So we do follow Maslow's hierarchy of needs in our music therapy sessions. I'm sure that many of you might have studied this or heard of this, but we really do seek to motivate the residents and engage them by providing a sense of security. And many people find security and comfort in music that is familiar to them. And in the groups, we also try to enforce a feeling of inclusion and belonging. A lot of the residents are from Haiti or from Russia or from other places, and so English is not their first language. So we do try our best to incorporate music that is in their language so that they do feel included. And we think that for many of the residents that self-actualization might be able to occur because of their sense of safety. So the question that I received was, how do you use music therapy or creative arts therapy to motivate a person? In music therapy, we use what's called the ISO principle. And that means that we are meeting the person where they are. So if a person is agitated, we might try to play music that might be a little bit more fast-paced. And then by doing this, we know that we are letting the person feel that they're heard and maybe misunderstood. If they're sad, we might start out with a slower paced song that might even have a theme of sadness. And then the music therapist will try to change the music gradually to get the person to a place that they feel happier or more relaxed. So I mentioned earlier that playing music that is familiar is very important, and we try to make sure that for everyone that we create a personalized experience to promote and encourage their participation. And this is something that a paid caregiver can do or a family caregiver can do as well. So one of the most studied techniques in music therapy in research is singing. And this can also be facilitated by a therapist or a caregiver. There's a researcher who's a nurse. Her name is Eva Gattel. She developed this technique for caregivers, specifically called music therapeutic caregiving. And so we know that music can stimulate language, or singing can stimulate language. We know that after a person has heard a song that's familiar, lots of times people will start singing. For people who have very minimal language because of dementia, we have noticed that they can sing, one or two words if the music is slowed down enough to give them time to sing. It stimulates memories, of course. It has an emotional response. So many people will start to talk because, the song reminds them of their favorite time in their life. Many times that might be during their 20s and 30s. It releases these happy endorphins and is a natural stress reliever. So for those of you who are feeling a little stressed as a caregiver, or you feel like the person that you're caring for is having a stressful time, try singing. It can really help. And it does offer a way for people to express their feelings. So they might not have the words to say what they're feeling in the moment, but if you play a song, sometimes it provides an opportunity for them to express to you how they feel. And it facilitates a sense of social connection, which is really important because, you know, a lot of times people with dementia do feel isolated. So this is a wonderful opportunity for people to come together and socialize in a way that they feel normal. So some tips really quickly that you might use at home or in a nursing facility is to add singing during caregiving procedures. The music therapist can't be there all the time, and many places don't have music therapy, but you can add singing during bath and shower time. Before lunch, I've heard people say that it helps to stimulate appetite for those people who might not be eating as well as we want to. We do try to incorporate singing. During the time that you're getting dressed, it distracts the person so that they feel like they're not, going to resist what you want them to do. So try singing during getting dressed. And if you are able to host a karaoke night with your family members. Music listening is also very powerful for those of you who don't feel comfortable singing. Music listening has also been shown in the research to reduce agitation and to improve mood. So try making a playlist, songs that are really familiar, songs that you think might be soothing, even paced. And for many people, they like to listen to spiritual songs. So if you're using music before bed, I know a lot of people have trouble sleeping or staying asleep. Try some music without words, and music that is slow paced. Here's an example of a playlist that we use all the time. At the top, it says relaxing, right? Or evening mix. So we don't necessarily only use it in the evening, we use it during the time of a day where we notice that a person needs, to be in a calmer state. So these are just some examples of some songs that you might try to use. It is best to, if you're creating a playlist, to use songs that, are familiar with people that you're working with or caring for. I use this actually for myself as well. And it's not necessarily music that I would have chosen. So I'm just giving you a tip. You might try to use some of these songs. Summertime by Gershwin is an excellent song, especially the version by Miles Davis, and What a Wonderful World by Louis Armstrong. And just to conclude, I wanted to it was hard to take a picture of the QR code, but if you want to see a virtual gallery of some of the residents' artwork, you can take a picture of this and go to the virtual gallery. I think that you'll find it fascinating and inspiring. My email address is here. My staff and I did create a workbook for caregivers, and it's called Music Therapy Keys to Dementia Care. If you just go to Google, you can easily just find this workbook and download it for yourself. It has many interventions that you might try. And finally, I just want to say that I am currently conducting a study for caregivers and people with dementia. This is for family caregivers who are living in the community. It is sponsored by the Alzheimer's Association. I do find that it is a wonderful support group for caregivers who might need that voice or ear for someone to listen to. I do teach people how to use music during their caregiving. So if you're interested, please reach out to me. And I just want to say thank you so much again for having me today.
Wow, this was great. My goodness, the content, the resources being shared, and I think this is extended to a very robust conversation that we're having both in the chat and the Q&A panel too. So really want to thank all of you for the incredible work you're doing. I'm certainly learning a great deal. I hope everyone in attendance is as well. Wanted to switch now over to our Q&A session here. Now, one thing I have noticed is many of our panelists have been very active in answering your questions on the Q&A tool. Really appreciate all of you using that up to this point. And again, I'm serving in a more moderating role. And what I'd like to do now with our wonderful panelists is to share some of the comments and questions that I've been gleaning both from chat as well as the Q&A panel, and kind of direct them to one or more of the panelists to discuss. And I'm going to start off actually with a recent question that Dr. Bonds Johnson wanted to answer live. So Dr. Bonds Johnson, as we look to establish a surveillance system to monitor the burden of Alzheimer's disease and related disorders in the community, we would like to stratify information about risk factors, comorbidities, et cetera, by race, ethnicity. Any suggestions for how to share information with a culturally humble approach to the Black community specifically? I thought that was a great question from Victoria Parker. So please, Kalisha.
Yeah, I didn't necessarily mean I needed to start with the question. I just felt like it needed the panel's expertise, and like one person couldn't address it. So I'll just initially say, I think one of the things getting into research, being in the space, being a clinician first, that has bothered me by a lot of the research that has been done on African Americans and Blacks is that we are often compared to non-Hispanic whites, as though non-Hispanic whites are the epitome of success, health, and then everybody else is kind of like, oh, well, you're not quite as good as they are, versus really coming in and understanding the strengths of the Black communities at large, and not just wanting to compare apples and oranges like we're comparing similar fruit. I don't think when we look at Black communities, Asian communities, Hispanic communities, non-Hispanic white communities, we all have a different experience within the United States. And if you can't come into that with a sense of wanting to see what the Black community does well and really highlight the strengths and a way to share what we're doing in a positive, I think culturally humble was used earlier, approach, then it may not be something you need to do. And you need to partner with individuals who are trusted in the community. I think it's a great way to do some of that community engaged research with individuals who are already in the field doing some of that work. And I would just leave it there and open it up to other panelists.
I totally agree with you, Kalisha. And I really don't have anything to add. I just really think you made a valid point, and it's something that I think that all attendees should take into account when we are looking at disparities and trying to really find out what is actually happening in certain communities, communities of color.
And I would just like to add that one of the things that we launched in the Center for Healthy Aging and Innovation at the U of M is a value proposition. Dr. Gogler led the way on this for researchers to fill out when they want to connect with community, because we want to make sure that community benefit is going to be there. And the follow-up and those aspects, but it's really to help us sort out, who and, is ready to connect and who might need resources before they connect.
Wonderful. Any other panelists wish to weigh in on this question? We certainly have many others to address.
I was just going to mention that there are quite a few programs working with African-American Black families, and it's always important to touch bases with the gatekeepers. It's very harmful just to go in and, offer a gift card or some money or something to get your research done. I think the proper and respectful way is to go through the gatekeepers and find out who's who and what's the best approach.
Wonderful. Thank you, everybody. Let's turn to another comment that came up in the chat I thought was really interesting. And maybe we'll start with you, Dr. Parker, just your thoughts and certainly other panelists. We're very, very excited to have an audience today, Dr. Peggy Dilworth-Anderson. She's joining us and has been providing some really insightful chats and resources. And one thing she presented, and I will share a link to this in the chat here after I'm done with kind of summarizing the comment, is encouraging not only researchers, but others to give comments on what is called the Federal Register Draft Guidance on Diversity Plan to improve enrollment of participation from underrepresented racial and ethnic populations in clinical trials. Comments are being sought on this document, and your knowledge is needed. All of you, family members, caregivers, others, play a pivotal role in clinical research recruitment of minority elders. And so I just wanted to share that with you. Again, many other great resources have been shared in chat, and we're going to save the chat and provide that to all attendees after the event today. But I wanted to highlight that one resource. I don't know, Dr. Parker or others, if you wanted to comment on this per se.
I think that's such an important question. And I think it goes to the point that Dr. Bonds was making earlier about we really need African-American and Black participants to enroll and engage in studies so that we can start to cite new numbers that really demonstrate the impact and influence of Alzheimer's disease and other related dementias in the community. So I think that it's great that there was a chat. I actually have another way that people can sign up and engage with those who are interested in being a part of nationally funded research studies, and I'll find that link and I'll put it in the chat. But always, it's so important to engage because there's a lot of factors and reasons why people say that African Americans do not participate in research, but that's a barrier. And it's true that there's a lot more representation. And even in the studies that I do, people get excited when they see, as we see a lot of scientists here on the call, when people see Black and brown faces, people get excited to engage in studies. So I think sometimes it's a misnomer. I think that it's really important to have science that's really culturally tailored, socially supported, and socially informed. And that really excites people to participate, encourages participation in studies. And I'll put that citation in the chat once I find it.
Thank you so much, Dr. Parker. And briefly to close this comment out, again, I hope, and I put this in the chat too, I hope all of you are available to attend the Robert L. King Memorial Lecture. Again, it'll be a virtual presentation by Dr. Dilworth-Anderson. It's going to be on social justice, clinical research, and dementia care in multicultural America. I think it's a great bookend to our conversation today. That'll be May 13th from 2:30 to 4 Central Standard Time. It's free to attend. We would love to have you. So I just wanted to make a plug for that. So again, we have a lot of other great questions and comments here. I wanted to share this one with Dr. Ray. I thought this was a good one here. Dr. Ray, is anyone working on family documents that have a list of information about their loved one that goes with them to the hospital, physical rehab center, nursing home, or assisted living that includes favorite music and hobbies? As a former rehab nurse, I frequently had patients who had fallen and fractured something, and then they spend a short time in the hospital, then come to the rehab on medications that aren't best for someone with dementia. These frequent transitions, along with these medications, cause delirium on top of dementia. As a midnight shift nurse with little contact with the family, my favorite technique to calm the patient was to play music from their teen years. So this is an avenue of work that I wish I had time to do. Thanks. And I know, Dr. Ray, you had actually shared a link of some of the work you're doing and some of the studies, but did you want to start by commenting on that? I thought that was a great point.
It is a really great point. And I'm not aware of anyone who has done work in this area. I know that in the long-term care facilities, within a few days of the person coming into the facility, we do assessments and then we gather information on what might work for a person as far as their musical preferences. But as far as the hospital setting, I think that since, I'm not aware of anything, I think it might be a good idea for caregivers to kind of take on that responsibility and figure out or find out what is your mom's, favorite music and what have you noticed at home that works to calm her. And then you can take that information when you go, to the hospital, and you might not wait for a music therapist to put their music on, or you might not wait for the nurse to put their music on. You might just bring your smartphone and your YouTube playlist that you've made and play that music for them, once they're hospitalized. That's what I'm encouraging my caregivers to do, because, there is a lack of music therapy in the hospital setting.
Wonderful. Anyone else on the panel wanted to address that? Or?
Well, I think one of the things is, I used to work in long-term care, and then I do some research in that area a little bit. And one of the things, there's no universal way of collecting that data. I found that each long-term care home, depending on the chain that they're part of, they do things differently. And so they have some nursing homes that collect this information, they do send it, and they have some that doesn't. And I think that we have to be informed. And if we don't see it, like Dr. Ray is saying, not just related to music, but ask for it. May you please, if you're sending my family member to the hospital, may you also please, do you have a sheet that you send with them that has their preferences? When I worked in a nursing home, yeah, we collect stuff. We had intake assessment, but what happened, I'm gonna be honest with you all, when we did it, where did we put it? In the chart. Did we ever go back to it? No. Mm-hmm. And then when we had our care meetings and stuff like that, things will be brought up, but we could have probably missed a lot of things or avoided a lot of things if we actually made that sheet active. And, Robbin always say like a living document. When we're talking, she says that. And so I think for those that are on the call, either if you're a caregiver, care partner, and you have someone that's in a long-term care home, facility, however you want to call it, that you be proactive, you ask those questions. And if for those that are working in these environments and settings, go pull out that paper and let's make some use out of it. Let's do something. Sometimes you don't have to have the policy to come from top down. And that's what a lot of people do that. They wait for the policy to come from top down. But if you see there's a need, maybe you bring it from bottom up and say that this needs to happen. And
wonderful. Thank you, Dr. Epps. Dr. Canterbury, I'm going to direct this next question for you. This comes from Tim Kaufman. Dr. Canterbury, you mentioned a study of statins and dementia, and thank you, Dr. Canterbury, for sharing all the great information on the preventable study. I just saw Dr. Canterbury provided very informative information on that in the chat. You mentioned a study of statins and dementia, but my question is whether there's any information about dementia and blood thinners. Thanks.
Yeah, thank you, Joseph. I actually still wasn't quite clear exactly what they were trying to learn. I don't know if they're able to add to that in the chat, but I generally kind of answered in the sense of just generally controlling chronic conditions can in itself reduce the risk of maybe any worsening dementia bouts in some conditions. So I'm trying to get a picture of what he's trying to gauge.
To my knowledge, I don't know of any link between blood thinners and dementia that have emerged consistently. I haven't seen anything. My best would be medications that seem to manage cardiovascular conditions effectively to some extent may reduce, at least overall, prevalence of dementia in the population. To be some suggestion of evidence in that direction, but again, I have a feeling there are a lot of nuances, particularly at the person individual level, that make it challenging to disentangle if someone is on a blood thinner, on a statin, et cetera. Actually, is that really associated with reductions in dementia? And the data is complicated. I think you would agree, Dr. Canterbury, but these are very important questions to answer from the standpoint of long-term research. We have a few minutes left, and I'm going to direct this one to both Ms. Harris and Ms. Frazier. I thought this was a great question from an anonymous attendee in the Q&A. Some African-American men and women who had professional careers and now have dementia seem to have a difficult time acknowledging and accepting they have the disease. They often put up roadblocks to services. This dynamic adds stress for family caregivers. Any tips or comments that might be helpful when this is the case? probably warrants a much longer answer than 2 or 3 minutes, but I'll defer to Ms. Harris and Ms. Frazier.
Okay, I'll start and then have Dorothea add in. I really think it gets back to the community. Often, you know, people having that stigma because they aren't seeing the people live with the disease. And so I think that professional that's now been diagnosed with Alzheimer's or another form of dementia is, you know, gonna need some time, as anybody does with the diagnosis, to research it and to understand, so they don't automatically go on to getting services. But I think part of what they need information on is the stages, and that they can be living and thriving with dementia. And so I think if we can start those, you know, early groups where people with an early diagnosis can come together, that will help address that. Dorothea, is there anything that you want to add?
I think you said it very well. Am I muted? Yeah. I think that you said it very well, Robin. I would just add that, you know, sometimes when you're dealing with someone of another caliber, you have to kind of come about it in a different way where they can be more contributors in the help with the research or supporting other caregivers or something, you know. But again, it's relationship, taking time, letting them know that this can be worked through. But yeah, you're absolutely right. The stigma is just huge, and you know, all people hear is there's no diagnosis. Don't worry about things. But we know that you can live and have a thriving life with dementia for as long as possible.
Yeah,
wonderful.
And I was going to say, and sometimes the benevolent care, or, you know, comes off very patronizing to them. And so you want to allow people to do as much as they can do. So they're not going to go from this person, you know, let's just say with a key role in a nonprofit, to being home all day. And so that's sometimes what happens, is people get lifted away from people and the things that they love and value. And so we want to let them live as vibrant of a life and as a productive of a life, because we all want to have that. We all want to feel like we make a difference.
What a great way to wrap up, both Ms. Frazier and Ms. Harris. Everyone, please join me in thanking this incredible panel. Wow, this was just wonderful. It was robust, vibrant conversation. And so much of it also is due to the great attendees here today with their really, really important questions, their relevant questions, and allowing us to share time together to learn and to build partnerships and community. And certainly in this context of dementia and dementia care, it's so needed. So again, thank you all for being here. I'm going to leave us with this final reminder. We'd like you to please complete the webinar evaluation that you'll be receiving. If you have any questions about this presentation or anything else, I encourage you to call me at this number here, and that is a link to my page. But again, you'll be hearing from Miss Ashley Millenbosch. She will be sharing with you the slides here today, the recorded presentation, as well as all the chat. We're going to save the chat because there were a ton of great resources included in there. I apologize that there were many other questions that we didn't have time to get to, but nonetheless, I hope that you enjoyed today's presentation, and be on the lookout. This was so successful. We may do it again if our panelists are willing to do so too. Otherwise, I hope everyone has a great rest of the day. Know that we're here for you. And if there's anything we can do to help, please don't hesitate to reach out to us. Thank you, panelists. Thank you, Ashley. Thank you all, and take care. Bye, everybody.